This is an MS Views Now program. My name is Stuart Schlossman, and I'm president and founder of MS Views and News, and that's a whole nother story. Tonight's program, as you can see, we have many sponsors: Biogen, Genentech, Bristol-Myers, Squibb, Sanofi, and Sandoz. And again, for tonight's topics and the speaker of tonight, we have Dr. Brian Steingo. And Dr. Brian Steingo is a MS neurologist in South Florida. He was with Sunrise Medical Group. Many people remember this, Tenet Healthcare, and it was recently bought out by the Steward Group. So he's with the Steward Medical Group, and he's a great neurologist down here. He's got thousands of patients, and we like to have him online. So tonight, he's going to be speaking about the topics that you see. And for those that cannot read the small print, we're speaking about dietary approaches in MS, future treatment options, and COVID MS updates. All right, doctor, take it away. I'll speak to you later on.
Okay. All right. Good evening, everyone. And thank you, Stuart, for inviting me to do this. The introduction, which I usually like to give always, is the land of MS. It's kind of an idea I came up with over 10 years ago when I first started doing programs with Stuart, to have something that would be comprehensive to deal with all the topics we could talk about with MS. So what I put together here was all the different topics that we can deal with in the land of MS, such as diagnosing MS, treating MS, the symptoms of MS, the drugs for MS, the nutrition for MS, social aspects of MS, wellness with MS, taking control of oneself, so-called self-power tower, so many different items. And if anybody has any input on things they'd like to add, or artistically how we can update this, that would be much appreciated. In the center of this, something I just made a brief recent changes. In the center, that circle says the land of MS, and I put in that section the control tower. The control tower necessary, the tower that controls everything else. So that would be me sitting there, and whatever topic someone would need to deal with, we would go out and deal with that topic. Right at the bottom is very important, self-power tower, stressing the importance of someone being involved in their own self. What I did add in the land of MS is something called the shopping basket, for a lack of a better name, but that's what I've called it right now. So what that meant is that when you come, every time that you visit with your neurologist or healthcare practitioner, there should be an item of questions that you might have. All of them are contained within the land of MS, and this was the shopping cart. I didn't know what to call this. I just called it a shopping cart. You're not really shopping, or maybe you're shopping for answers. I was going to call it the Amazon cart, but I thought, no, we can't do that. So I just called it a shopping cart. And what I listed here was probably the most common questions that I deal with in my practice on a daily basis, and saying to any given person, when you come in for your visit, what particular item are we going to be discussing? For example, is it an update in MS, MS 101? Are we going to talk about your disease-modifying drug? Are we going to talk about fatigue, or the bladder, or the bowel, or exercise, or diet, etc.? We could pick any number of these topics to discuss at a given point. So what Stuart has asked me to talk about today, particularly in the short time available, is 3 topics. The first topic that we're going to talk about is diet and MS on the shopping cart. That's item number 13, just to talk about a little bit about dietary aspects of MS. The next item was about COVID and MS. That goes under item number 14, which is comorbidities, other diseases associated with MS, their effect on MS and the effect of MS on those conditions. And then finally, Stuart asked me to talk about, say, future therapies, and also biosimilars, which would refer to the second item on the shopping cart, which I refer to as the DMT update, the disease modifying therapy update. So these, we picked some topics out of this whole long list that we're going to concentrate on tonight. Each one of these, of course, we could spend hours on. So first topic we are dealing with, as Stuart requested, is COVID-19. And the question about COVID-19 is, what is the effect of having MS if you get COVID-19? And infections in general, we know, may cause new symptoms or new MRI activity. This can be any infection. Commonest is urinary tract infections, but any infection, with a fever especially, can cause a worsening of symptoms, and in turn can trigger an MS relapse. Of course, the most common infection that in history that has triggered MS relapses appears to be Epstein-Barr virus. And as most of you are familiar, Epstein-Barr virus is now a very hot topic in MS. But specifically, since infections may trigger COVID-19, since infections like COVID-19 may trigger an MS relapse, that is something we'll address. What about the severity of COVID-19? Several MS registries have looked at this, and this appears to be related mostly to two things. So just the fact that someone has MS, getting COVID-19 doesn't mean that they're in trouble. There are two things that appear to be important in how severe someone's result is of getting COVID-19. The first is comorbidities. So this is similar to conditions that other people may have. For example, cardiovascular disease, heart disease, diabetes, kidney disease, pulmonary disease, cancer, obesity. All these factors, and of course age, all these factors that are a risk factor for anyone who gets COVID are similarly risk factors for anyone who gets COVID that has MS. From the MS standpoint, the major additional risk factor is the severity of the MS. So in all the registries, such as COVI-MS, which I have quoted for you at the bottom of this slide, COVI-MS was a more local North American registry, but in COVI-MS we found that people's outcomes were related to their severity. So, for example, people with more progressive MS, more disability, had worse outcomes than people with less severe disease. Now, in part, that is related to the fact that people that have progressive MS generally tend to be older and more frequently to have comorbidities. So these are some of the items that help us in trying to predict outcomes. So what do we recommend for people to do? We recommended that they get vaccinated and boosted according to the guidelines. Now, are there exceptions? Of course, there's exceptions to everything. There are people that will get a vaccine and have a reaction to it. Similarly, there are people that have the flu vaccine or polio vaccine or shingles vaccine. There are some people that unfortunately may react to any vaccine. But the numbers of people that have reactions is very small. And the protection afforded by a vaccine is much higher. The risks to the benefits, clearly the benefits outweigh the risks. So we generally advise our patients with MS not to delay starting and to take the vaccines as recommended. So these are the recommendations, not of me personally. They are of me personally too, but they are certainly the recommendations of all the major organizations, the National MS Society, the United Kingdom MS Society. All major MS organizations would recommend that people should take their vaccines as recommended. Now, there are certain drugs where we have to consider what the drugs are. For example, on Ocrevus or Rituxan, the way these medications work is by reducing B cells. B cells are a certain type of white blood cell, and they are responsible for forming antibodies. So therefore, if someone is on these drugs, they need to be vaccinated typically before they start the infusion. If they have already started their infusion, then we would wait a while along the course, at least 12 weeks, and in fact, maybe a little closer to their next infusion before they take the next dose of the vaccine. The next section deals with Mavenclad, which is cladribine, the S1P drugs, of which we now have 4. The original one was Gilenya, fingolimod, and we now have 3 newer ones, Mayzent, Zeposia, and Ponvory. So 4 drugs in that class, and then Kesimpta, which works similarly to Ocrevus. And similarly, if someone is starting these drugs, we recommend they take the medication, the vaccine, before they start the medication. Otherwise, we would have to always discuss the timing. It turns out that they have done studies on some of these drugs. The vaccines do have some effect, but it is reduced. It is less than it is on some of the other drugs. For example, on the interferons, on Avonex, Betaseron, Rebif, any interferons or Copaxone, or even Tysabri, taking the vaccine may occur at any time. And then, of course, we always are stressing being aware of our community resources in case someone has an infection and what could be done at those particular times. So the dominant variant now is the Omicron BA.5 variant. This generally is a milder illness than Delta, but it is more easily spread because people have not had this variant as much. It generally, therefore, will cause a milder illness, but it will spread more rapidly because less people have had it. And we think with time, more variants are likely to emerge. Now, some people have said that this is like the common cold. We may just have aches and pains and runny nose and cough and things like that. And that is true in many people, that the purpose of the vaccines is to reduce the severity of the illness, but it cannot prevent it, but it can reduce it. So the people that have done worse when getting the new variants are people that are not vaccinated or people that are in the vulnerable groups that we spoke about earlier. The good news is that there is constant vaccine development going on, and there are new variants which may be, hopefully, a universal coronavirus vaccine that may give us some protection against all coronavirus strains. Now, coronavirus, COVID-19 was considered and probably primarily still is a respiratory disease. And we're going to talk about some of the long-term effects of this in a moment. But it can damage other organs, including the heart, kidneys, and the brain. For example, with the heart, it can cause myocarditis. Let's just dispel something about myocarditis. Cases of myocarditis have occurred with the COVID vaccine, especially in younger males. But the frequency is much less than the amount of myocarditis that has been seen with COVID-19 itself. Some advances, and this is not new, this has been around for some months, some time, is Evusheld. Now, what is Evusheld? This is for prevention of COVID-19 in certain individuals. And you can see that it is a combination of two antiviral drugs, tixagevimab and silgavimab. As you may recall from other MS drugs, anytime you see the words MAB in a product, that stands for a monoclonal antibody. This is an antibody that is directed against something specific. So a combination of these two antiviral drugs is contained in the drug called Evusheld, which is given by injection. Two separate agents with two injections that are given. So it's really, when it's approved, said to be strictly for those not to be able to mount an adequate response. For example, people with malignancies, transplants, and HIV. However, as we covered early, some MS patients may be likely to mount lesser of a response or have more severe disease, especially people on the B-cell depleters such as Ocrevus or Rituxan. And so on those patients, there could be discussion for this. If I see someone who is at high risk, this is an agent to consider. Another group that is at high risk is pregnant mothers. Pregnant mothers have worse outcomes with COVID-19. Pregnancy is a state of impaired immunity. A woman who is pregnant has impaired immunity, and so we do whatever we can to protect. Warnings and precautions include cardiac disease. In people that have had cardiac disease, we have to consider this more carefully. Cardiac complications on Evusheld are higher. So that goes also to the cardiovascular disorders mentioned a little lower. Anybody can have hypersensitivity to any drug. Shock, hypersensitivity can happen with this drug as well. If people have a bleeding history, for example, if they have low platelet count, this medication should be avoided. And finally, most common symptoms you see at the bottom here are headache, cough, and fatigue. This here is the health footprints of COVID-19. What happens when COVID-19 appears in the world, in a community? What are the outcomes? Extending way beyond, number one, the first wave, immediate morbidity and mortality. People that are sick and people that die. This is the first wave. Unfortunately, that's not the end of it. Especially when COVID-19 started, there is such a huge strain on resources, so many restrictions, hospital beds full, that people have other urgent non-COVID conditions are excluded, cannot get into the hospital, cannot get into the ER, cannot get adequate treatment. And we saw this at the beginning, how many people with other urgent non-COVID conditions were suffering and not being treated adequately because of no resources. And then thirdly, what about the impact of care on chronic conditions? People with chronic conditions not able to get care because of falling resources and because of fear of going into the community. So that's the third thing. Now the effect on chronic conditions. And finally, there's the long-term effect of COVID, the effect of mental stress, the economic impact, burnout of physicians, burnout of healthcare practitioners, burnout of people with COVID. The effects on the community are tremendous. So these are all the health footprints and waves of COVID beyond the initial illness. There is this very important consideration of long COVID. So what is long COVID? The good news is that in many people with long COVID, they may eventually recover, but it may take a long time. But what this is new symptoms or worsening symptoms that people experience for weeks after their COVID. More than 4 weeks after having COVID, they are still experiencing symptoms. And what causes long COVID? We don't know, but there are certain factors that I've listed over here that contribute. So the first is that there's, of course, direct damage to cells. The virus damages the cells, for example, often in the lungs, and there could be lingering lung symptoms, coughing, breathing difficulties that go on, and other cells may be damaged potentially, as in the brain. Then patients may have chronic hospitalization. Chronic hospitalization for any cause is severe, whether it's for COVID-19 or a stroke or some other condition. People are bedbound for weeks. They become weak. They lose weight. They lose muscle. They lose bone. So this can happen with a chronic illness like COVID as well. People have mental and psychological and memory problems. So the effects of chronic hospitalization contributing to long COVID. But even after the acute recovery, we know that there may be persistence of virus in some of these cells, and that the immune system may be altered, and that this abnormal immune system, as you can see here referred to as a dysregulated immune system, this abnormal immune system may have some long-term implications. Similar to what happens in MS when we have an abnormal immune system that continues to attack our nervous system. We have an immune system disease as a result of COVID. So what are the symptoms of long COVID? If you look through these, you'll see that loss of smell and taste may be ongoing. There can be fatigue. It's interesting, there is study of this fatigue. We're studying the fatigue of MS. We don't understand it. Potentially, this fatigue down the road may have similar implications to MS fatigue and may even be managed the same way. There's some exciting research going on with MS fatigue for the future. People may feel weak, short of breath, coughing, pain, localized pain, generalized pain, sleep problems, difficulty concentrating, headaches, depression or anxiety, and dizziness. All of these symptoms can go on with long COVID. Here is something important. Which groups do we see more of this in? We see it more in people of older age. We see it more in people that are of female gender. We see it more in people that are active smoking. And at the bottom, this final statement says that it didn't depend on the severity of the acute disease. However, there have been some recent papers that have said the severity of the acute disease may in fact be important. It makes sense that it's important, because if someone was more sick, they usually would have a worse viral attack. So I think that severity of acute disease may be more important than this original statement said. And by the way, in that last slide, this said it was worse in female gender, which contributes to why COVID-19 is also worse in pregnancy. Now, what about information and support groups about COVID-19? Of course, MS Views and News, thank you, Stuart, is putting out constant information and updates about COVID-19. The National MS Society, the MS Association, these associations are always putting out updated news. They're international organizations. Facebook, there are Facebook pages and Facebook information. And then Survivor Corps is a large grassroots movement in America which provides education and resources for COVID patients at survivorcorps.com. So these are some other sources of information that you could find on COVID-19. Thank you. Okay, so that is all I want to say about COVID-19. You've had other talks about that. I wanted to talk about this subject, which is a subject very close to that I talk about very much, and that is MS, diet for MS, and nutrition. And firstly, to say there's no widespread condition. There are many different diets that have been proposed. Some people think dietary factors are very important, some don't, but there's a lot of evidence that diets may be important. And at the bottom, I've listed a summary of some important facts. And the important facts are that the diet, we do favor a plant-based diet, which is whole grains, fruits and vegetables, unsaturated fatty acids, legumes, nuts and seeds, and it's against red meat, dairy, sugar and salt. That means that these should be in small amounts. So this is not meant to convert someone into a vegan. This is meant to say that the diet should be plant-based, and that these other items, such as red meat, dairy, sugar, and salt, especially red meat and dairy, we should have very minor amounts of those. And the sugar, yes, sugar and salt, I think should never be added components of the diet. This summarizes everything that we're about to discuss. Why is diet so important? Because how do we modify MS? We may be born with genetic risks. So some of the theories, we may have some genetic risk that we're born with, and then something happens to us and stimulates the MS, activates it. For example, the common cause that we talk about now is Epstein-Barr virus. Some neurologists have gone as far as to say they think Epstein-Barr virus is the cause of MS. Right now, it's not important per se because we don't have a cure for Epstein-Barr virus. If we did, that would become very important. But in any event, what we know is somebody has the genetic tendency for MS. Some risk factors are exposed to trigger it off. So we're saying, are there any risk factors that we can modify? We can't modify all the risk factors. We can modify some of them. Well, diet is one of them that we can modify. If we modify the diet, we may be able to reduce inflammation in the gut, inflammation that may slow and prevent and protect against neurodegeneration and promote repair. The things we're always looking to do in people with MS is to stop or reduce the inflammation, to protect against neurodegeneration, and then to promote repair. All our research going forward looks at these aspects. What about dietary factors? What are the pathways? There are indirect dietary factors, such as our diet of reducing cholesterol and body weight. This has an indirect effect on metabolic factors. And then we have a direct effect of the diet, for example, on metabolic production in the gut, in the gastrointestinal tract. Now, I'll review some of the diets, because people always ask me about these. The Wahls protocol, as you see, is a diet that eliminates starches, wheat, grains, legumes, and dairy. Therefore, this is a diet I don't favor, because I told you at the beginning that I think a diet should have whole grains and legumes. But this diet favors grass-fed meats, wild fish, leafy greens. Dr. Wahls wrote this diet after her own personal experience. And the McDougall diet is the opposite. Look at this diet. It eliminates meat. This is a vegan diet. It eliminates meat, eliminates dairy, oils, and processed foods. This diet favors legumes, corn, rice, and sweet potatoes. What do you see here? Two opposites. One says no legumes and have grass-fed meats. The other one says no meats and have legumes. In the studies for these diets, both diets have a positive effect on MS fatigue. One thing they do have in common is they both eliminate dairy, and they both include colorful fruits and vegetables and avoid processed foods. So our take-home message, that things that stand out from these diets is have a lot of colorful fruits and vegetables. I'm saying plant-based diet. Avoid processed foods. Eliminate or minimize dairy. Next, please. The initial MS diet was the Swank diet, published in the 1950s, follow-up publications in later years. This was before we knew anything about MS. In the 1950s, we had no MRI scans. We knew nothing about MS. And they put 25 people, Dr. Swank did, on a very low-fat diet. And then he followed subsequently another group of people for 34 years. Can you imagine a 34-year study? And that study was published in The Lancet in 1990. What were the results of the small study and the larger long-term study? 95% of the people who had a diet that was low in saturated fat did not have progression of their MS. And after 34 years, in that small group, the death rate, they had a death rate of 31% compared to the other group, which was 80%. In other words, the death rate was half as much as the people that had a typical high-fat diet. This was the Dr. Swank diet. Dr. Swank himself worked until his late 80s and died at the age of 99. Maybe he followed this diet. But this is more information about avoiding processed foods, avoiding saturated fat, and having unsaturated fat in the diet. Other diets, the paleo diet. Now, this diet has meat. It's lean meat. Again, you can see fruits, vegetables, nuts, and seeds. And these are the foods. The characteristic of a paleo diet is a diet that has foods obtained by hunting and gathering. So it limits foods that became common when farming emerged 10,000 years ago, including dairy products, legumes, and grains. Of course, avoids salt, sugars, processed foods. It's foods that you could have eaten as a caveman. The keto diet has become a common diet these days. And the keto diet is a high-fat diet, but it's not saturated fats. And it's got moderate proteins and very low carbs. So most of it is fat, 30% protein, a small amount of carbs, only about 20 to 50 grams of carbs a day. So what happens in this diet is you're not eating carbs, therefore you have more fats, and you enter a state of ketosis. In other words, the body is breaking down fat to provide energy. Instead of sugar, you're relying on fat. You're breaking down the fat. When you break down fat, you form ketones, and that's why this is called a keto diet. It's a fat diet, but we are going to use unsaturated fats for this diet. Let's look at fats for a moment. And look over here at saturated fats as the first type. And we've already said, going back to Dr. Swank, 70 years ago, we know that saturated fats, we want to avoid those. And then there are two types of fatty acids. There are short-chain and long-chain fatty acids. Long-chain fatty acids are the ones that are found in processed foods. And they can produce or stimulate pro-inflammatory T cells. And in MS, we have a disease where there is too much inflammation. We don't want to promote a cell that produces inflammation, so we need to avoid long-chain fatty acids. Whereas the short-chain fatty acids lead to production of anti-inflammatory cells. Where are these produced? In the gastrointestinal tract, in the intestine, by the bacteria in the intestine, by what we call the intestinal microbiome or microbiota. And we can have polyunsaturated fatty acids, and that's an example of that. There's omega-3, walnuts, flaxseed, very good for us, or monounsaturated fatty acids, olive oils, avocados, nuts. So the stress again is avoid the saturated fatty acids and use the mono or polyunsaturated fatty acids and the short chain fatty acids. That is what we're striving for in our diet. How about MS and nutrition and the dairy aspect? So there was a study done called the Nurses' Health Study. And the finding in this study was that nurses who consumed 3 or more servings of whole milk a day in adolescence, so are we telling our children to drink lots of milk, were 47% more likely to develop MS in later life than those who did not. This is one study, the Nurses' Health Study, and it's what's wrong with dairy. Dairy has got a lot of fat, often saturated fat. There are other findings we know about in adolescents that can increase their risk. Obesity in adolescents increases their risk for MS. Vitamin D deficiency increases the risk. And here is more evidence that we should not push saturated fat in the milk, and we should be aware of this. The holism study. In the holism study, another good study for MS, patients who reported not consuming dairy were less likely to report recent disease activity, and their quality of life was higher than those who reported consuming dairy. So another important study. And then in Europe, at the universities of Bonn and Erlangen-Nuremberg, they found a possible cause as to explain this. And what they said is that there is a protein in cow's milk that can trigger inflammation of myelin. They demonstrated this link in mice and found a similar mechanism in humans. These are all ongoing studies. And therefore, if someone is diagnosed with MS, should we tell them, do not drink milk because there is a protein in milk that can stimulate inflammation. And all of this goes back to the very first slide I said of minimizing or avoiding dairy. In terms of meat, it's avoiding the saturated fats. This is what I call defensive dining. It summarizes my thoughts on this, which is basically, aside from controlling the content of your diet, which we spoke about before, legumes, whole grains, fruits, beans, seeds, avoiding processed foods, minimizing meat, no saturated fats, no processed foods, I've said that, sharing, reducing the size of the portion, eating slower. The brain in the way of eating slower is that as you eat, your brain starts to get the impression and get the understanding of how much you've eaten, and therefore may slow your appetite. If there is a salad dressing, put it on the side, have a low-calorie, low-fat salad dressing. Remember, alcohol has calories. Avoid obesity, avoid salt, sugar, and saturated fats, limit red meat and dairy. I call this defensive dining. What about the gut and the microbiome? Dr. Howard Weiner is a foremost researcher in MS and said that the gut may be the next frontier in MS therapy. In other words, we spoke about this before. What modifiable factors do we have? It's what we eat. What we eat affects the bacteria in our gastrointestinal tract. The bacteria in our gastrointestinal tract are a huge part of our immune system is in the gastrointestinal tract. These cells that you often hear about with MS called lymphocytes, the white blood cells, there is a huge amount of them in the gastrointestinal tract. And so we find different amounts of bacteria, and different studies have shown that in people with MS, some of these bacteria are different from bacteria we might find in healthy people. Some may drive inflammation, some may reduce inflammation. So if we change the diet, can we change the bacteria? This is all very exciting future research. Next, please. And that's called the microbiome. It's the bacteria that are affiliated with our bodies, most of these in the gastrointestinal tract, and bacteria on our skin, but it's the ones in the gastrointestinal tract where there are literally trillions of bacteria living with us, and these all have genetic components, and these bacteria benefit from living in our gastrointestinal tract. They have a home, they have a food supply, and they provide us with metabolic factors. They provide digestive functions. They are involved intimately in regulating our immune system. So there is this two-way process between us and the trillions of bacteria going on. And in the future, I think in modifying these bacteria and finding out which the right ones are, which are the right probiotics, is going to become an important part of MS. So I think probiotic research, probiotics, prebiotics, I think all of these as part of our diet are going to become very important aspects of MS in the future. Here is something about supplement research that is very exciting, and it leads us on to the next topic almost, which is that Stuart wanted me to talk about some future research. And so this includes a link between what I just talked about, diet and research. And the first item to point out is glutathione. So in MS, we know that there is inflammation. That is the first step. When the immune system is activated, there is inflammation. And there is neurodegeneration. There is a degeneration of myelin and degeneration of nerve cells, axons, that is going on. But in addition to that, when everything is activated, there is oxidative stress. And when there is oxidative stress going on, this causes further damage. So we're trying to find a way to reduce this oxidative stress with certain antioxidants. So glutathione is a very important substance. It is the major antioxidant in the brain. And it is important in detoxification of oxidants. And in MS, glutathione homeostasis, the regulation, the environment for glutathione is altered. How do we affect this? Some people are actually administering glutathione infusions. But a very interesting to me topic is the next one, which is N-acetylcysteine. There's been talk about this for a while as a neuroprotective agent in progressive MS. And so there is a trial going on in California at a major institute for N-acetylcysteine, and it is available. You can get it in various ways already, but we don't know doses. We're learning more about it. So what does this do? This is to reduce the oxidative stress. It scavenges the free radicals. When there is oxidative stress, there are what are called radicals that are causing inflammation and attacking the neurons. And N-acetylcysteine is a powerful antioxidant. And the research on this, I believe, is going to show some very interesting results. What has been around for a longer time is alpha-lipoic acid. Now, have there been big studies in all of these? No, because these products are very hard to study. They're expensive studies. Who sponsors them? Products that are much cheaper than any agents. So alpha-lipoic acid is another drug that works against oxidative stress, another antioxidant. Where is alpha-lipoic acid found? It's found in some foods, but in small amounts, such as spinach and broccoli, in small amounts. And it's also found in the liver, but to really get the adequate amounts, we have to supplement this, and we make recommendations of the doses, such as 1,200 milligrams daily. And it's been shown in some trials that if you take alpha-lipoic acid, it reduces the markers or the signs of inflammation of cells that are migrating to the brain and the spinal cord. So this is some more dietary aspects, and I think we'll find more of these things in the future, of some natural things that can help us reduce inflammation. So going straight into the therapy section of future therapies, a lot of very great interest now in new groups of drugs. So we have, as you know, over 20 different agents and generics that are approved for MS. But a whole new category that's coming about is called Bruton's tyrosine kinase inhibitors. And these are being studied in MS, both relapsing remitting MS and secondary progressive MS. It works predominantly by modulating the B cells. So we know there's different kinds of white blood cells that are called T cells and B cells, and this particularly modulates B cells. Here is the important thing that this drug does. It's different from some other drugs that we know. It works on microglia. What are microglia? They are immune cells in the brain, in the central nervous system. So here we have a drug that might not only work on the peripheral B cells in our circulation, which may do their damage by crossing into the brain and spinal cord, but it's also working maybe directly on the immune cells in the central nervous system. So Bruton's tyrosine kinase inhibitors, several companies are researching these. I anticipate hopefully by 2024 that the first group of these will become available. Masitinib is another tyrosine kinase inhibitor, but it's different from the Bruton's inhibitor, and it's been studied in progressive MS. There are ongoing studies. It appears to have some promise, was not totally conclusive, and hence there are still studies going on with masitinib. And then, of course, we have stem cell transplantation, which is a big topic. True stem cell transplantation, which is when use autologous or our own stem cells that are then processed and injected back into our bodies. In order to do this, we alter or destroy the immune system. Then we replace the transplanted healthy stem cells to help us regenerate a new or fresh immune system and decrease inflammation. It's basically to reset the immune system. It's a powerful therapy that is quite effective. It's not a cure, but it's a very effective therapy that is expensive and is still undergoing research. Next, please. I'm going to talk now finally about the subject of biosimilars or generics. What is a biosimilar or generic? These are both cheaper versions of our current name brand drugs, which are costly. And so we're constantly seeking cheaper versions, and that's what biosimilar or generics are. So when are these available? So when any drug is available, there is an exclusive patent on a drug that expires after a certain amount of time, 10 years or whatever it is, 20 years, whatever the amount of time. After that amount of time, the patent expires, and now we're trying to find a cheaper alternative. And so we have biosimilars or generics. These are very different. Generic drugs are identical to the original. It is a chemical composition that is identical. It's a chemical and it's made and it's identical. A biosimilar, though, is not identical in composition, but it's highly similar. It's close enough that it accomplishes the same effect and the same result, and ideally the same safety. So therefore, it is biologically very similar. So the difference here is that generics are copies, as I said, of a synthetic drug. It's a chemical, straightforward chemical copy, the same chemical, but a biosimilar is not the same chemical. A biosimilar is modified after a biologic. A biologic is a drug that uses living organisms as an ingredient. So a biosimilar is modeled after the biologic drug, and it will use living organisms, bacteria, etc., as an important ingredient. A biosimilar is an FDA-approved drug. It's undergone extensive regulatory investigation and evaluation. To prove that it has the same safety, must make sure it's safe and efficacious and have the same quality. So those are what biosimilars are all about. Next, please. So biosimilar or generic, branded drugs could be either one of these. As I said before, a synthetic means it's made from a chemical process. A biologic means from a living source. The synthetic branded version exactly replicated into a more affordable generic version, but a biologic, which is made from living organisms containing those, involves a very large complex molecule. So in a systematic review of 90 studies on switching from a reference medication brand name to a biosimilar, looking at 7 biosimilars across 14 disease states and 14,000 individuals. The majority of publications did not show any difference in immunogenicity, safety, or efficacy. It's very important that if someone is stable on an agent and then a cheaper agent becomes available, that we wanted to provide the same degree of safety, efficacy, and effect on the immune system. So I think that concludes. Yes, that concludes the slides. So good, Stuart. I've left good amount of time for questions.
That was excellent. Thank you very, very much. I find that your talks are so educational. Isn't that great? I mean, I don't know why you don't like to speak more.
It's not up to me. It's up to you. I talk all day long in the office. In the clinic, I talk all day long. So
I know that. I do know that. All right, so that's great. So we had over 70 people online tonight, and that's a fantastic audience. And I think that's because, Doctor, they actually, they wanted to hear from you. They wanted to hear about these topics, and I think that is awesome. So I want to thank everybody that is online, all right? Let me get started. There's a lot of questions. First one is from a Carolyn. If you're taking Gilenya and have had the J&J COVID vaccine and several boosters, would you recommend taking the new Omicron booster or Evusheld?
I mean, the timing depends. The question I would ask first is, when was the last vaccine, of course. In general, when people have had the J&J vaccine, I think that the Pfizer and Moderna vaccines are more effective and have less side effects. So in this situation, I would recommend taking that the next vaccine be the the new Omicron protection vaccine. The new Moderna Pfizer booster is what I would recommend.
Okay. What do you recommend for people, though, that have had COVID? Do you recommend them getting another booster? Do you recommend it based on the timing of when they had COVID?
Yeah, it depends on the timing. At least I would say 3 to 6 months.
Okay, thank you for that. Next, Karen is writing, wellness question. Is it now safe to work at a gym considering COVID? I'm on Aubagio and considering Mavenclad.
Yeah. In terms of Aubagio, there is no increased risk. Aubagio is not a drug. If someone acquires COVID, Aubagio does not increase the risk. So being on Aubagio is not one of the drugs that increases the risk. It generally does not lower the white blood cells significantly, and it is not associated with a higher risk if someone acquires a COVID infection. In people that are high-risk people, I would look at their risks in terms of where to go out. As you know, if you go out into the society, you see very few people wearing masks these days. This applies to going to restaurants or flying on planes. The majority of people are really not wearing masks, I would say. That said, if someone is at a higher risk, and Aubagio is not something that puts someone at a higher risk, but if someone's at a higher risk, they have more severe MS, they have other risk factors, comorbidities, diabetes, heart disease, for example, obesity, other risk factors, I would say they could still go to a gym, put on a mask, and work away from the crowd. Time yourself, locate yourself, but exercise is very important. If someone doesn't go to the gym, they need to find an exercise program at home. Now, one of the biggest problems that's happened during COVID is people becoming deconditioned. So deconditioning has been a major problem. A lot of people that have weakened and have had a worsening of symptoms are because they're deconditioned. So doing an exercise program, whether it's a gym, taking precautions, or continuing to exercise at home, I certainly stress that exercise should be continued.
Thank you for that. Deborah is asking, are there any DMDs or DMTs used for patients with disease disability progression who don't have changes in MRI?
Yeah, I mean, if you looked at my basket at the beginning, the shopping basket, and we did 3 of the 15 topics, this in itself is a huge topic, is what to do with progressive disease. So there are 2 types of progressive disease that we deal with MS. There is primary progressive MS, which is someone who starts out right from the beginning with slow progression of their MS, or maybe not so slow sometimes. And then there is secondary progressive MS, where someone used to be relapsing, and then starts to progress, so-called secondary progressive. Now, as we're learning more about these, a few things have happened. Number one, we have a new category of secondary progressive that's come about in recent years. It's called active secondary progressive, which allows us to use more drugs because we feel that's almost a variation of relapsing. In fact, it might be the transition or the gray zone between relapsing and secondary progressive. On the other hand, there are some people that think secondary progressive and primary progressive are the same. The end result is the same, and they're not really that different. There are just maybe different degrees of neurodegeneration. Most of the drugs that we have for MS to date are drugs that work for inflammation. That's why they work better for relapsing, because relapsing is a predominantly inflammatory disease. But even in degenerative or progressive MS, there is some inflammation going on, but it's dominated by degeneration, which is why we're looking for new avenues, maybe like some of those supplements that I talked about that maybe can work for that. So the only approved medication for progression without activity, meaning progression when there's no more relapses or there's no more inflammation, the only approved drug for that is ocrelizumab, as we know. But if there is some activity, and we're always going to search for activity, then we can use a wide range of the other medications.
Great, thank you. All right, next we have Cindy. Cindy's going to ask a very difficult question. How do you distinguish diagnosis between IBS-C and neurogenic bowel dysfunction, which could indicate MS progression?
Neurogenic bowel dysfunction is a topic that's become more and more widely recognized. Probably if you went on the internet and did a Google search and looked for a neurogastroenterologist, you might even find some people that put that title on themselves. But we've had for a while with the bladder, we've known that the urologists who are, especially in big centers, big clinics, that neurologists who know a lot about neurourology. Neurogastroenterology is a much newer topic. And generally the major manifestation of MS on the gastrointestinal tract, one of the best known is gastroparesis, which is a slow emptying of the stomach causing a lot of indigestion. But at the same time, there can be involvement at the opposite end, and people may have impaired bowel control as a result of the neurological problems. And there's no easy, there's no easy way. We can do to determine what's going on in terms of MS. There could be suspicion. If someone has MS and they have a neurogenic bladder, and then they have some bowel problems, it would be suggestive that they could have a neurogenic bowel as well. But the study of the bowel can be undertaken, and what can be done is called bowel motility studies. Not everyone does those, but there are specific centers that do bowel motility studies. And in the centers that do bowel motility studies, they can find out how the bowel motility is. They have instruments that they can put in upper and lower gastrointestinal tract and measure bowel motility and bowel function and make recommendations. The treatments often or may not be different. For example, if someone has gastroparesis, say from diabetes, or gastroparesis of MS, the treatment of the actual symptom is not much different. It's telling people to have small meals more often during the day, etc. And so similarly, if someone has impaired bowel control or very hyperactive bowels, whether it's from IBS or the MS, the treatment of the symptom may be very similar. But it can be evaluated by doing bowel motility studies. So someone who has this problem should look into a gastroenterologist that does bowel motility studies, and they will be able to evaluate this better.
Okay, thank you for that. Next question. As somebody's asking, I will be switched from Ocrevus to Vumerity to treat MS. What do I need to consider before getting the COVID booster?
So in terms of Ocrevus, we know that Ocrevus lowers B cells specifically, and so someone's lymphocyte count might be low. In terms of Vumerity, Vumerity only has one serious side effect. It is very rare. That is because Vumerity is part of the class of groups called fumarates. The original one in that group was Tecfidera. We now have Tecfidera, we have Vumerity, we have generic dimethylfumarate, and we have another drug called Bafetame, which is monomethylfumarate. So we have 4 agents, but there's several generics. We have several agents in that group which all work the same way and all have the same potential severe risk of PML. Now, the PML risk is very low. There's maybe a dozen cases out of several 100,000 people, so it's very low. But the one thing those people have had in common is a low lymphocyte count. So lymphocytes need to be monitored very carefully certainly the first year every 3 months, because the risk is seen when people have a very low lymphocyte count. So how does this go back to your question? When someone is starting the medication at the beginning, we need to make sure they have an adequate lymphocyte count. If they've been on Ocrevus, we want to check their blood count, make sure they have adequate lymphocytes before they start Vumerity. If they have adequate lymphocytes, then they can take their infusion and start Vumerity. And by the way, once someone is on Vumerity, there are no restrictions in terms of when they can take the vaccine. Unlike an Ocrevus, when the timing of taking the vaccine is very important, when someone is on Vumerity, the vaccine can be taken at any time.
Okay, thank you for that. Next, a person writes, I would like to hear more about PPMS research and new medications. I'm 69 and have had MS for 30 years and am in a power chair. The JC virus showed up in my blood work, which I had no knowledge of, but excludes me from Ocrevus. So what else can I look for?
All right. I mean, when I answer a question like this, I'm going to give you a general answer. You can't give a specific answer always. A number of answers to this. Number one, if somebody has progressive MS, the only approved drug for that is Ocrevus. The side effects of Ocrevus are greater in older patients. Why? Because it's affecting the immune system. The immune system in an older person is more susceptible to side effects like infections. So when we use Ocrevus in an older MS patient, which probably is anybody over the age of 55 or 60, we need to be aware of the risk of infections. Now, people that are older also more commonly may have comorbidities like diabetes. They may have neurogenic bladders. We've already referred to a bladder problem, and therefore could be at a higher risk of infections, especially urinary tract infections. And urinary tract infections and urosepsis are very important causes of morbidity in MS and even death in MS. So we want to be sure the bladder is working fine and there's no risk of infections. If that's under control, so that's part of looking at an older person saying, what's the risks and what's the benefits? If we're certain that they're getting worse because of their MS, Ocrevus is the only approved drug for progressive MS. And we need to look at the risks and the benefits and say, okay, your bladder's working fine, we're going to monitor you very closely, and Ocrevus may be the approved medication for you in this situation. In terms of PML, JC virus is not routinely measured for patients on Ocrevus. I never measure it per se for someone on Ocrevus, ever, never. If I'm not sure, when I see someone what drug I'm going to put them on, if Tysabri would be a consideration, I'd measure JC virus. If I'm putting someone on Ocrevus, I never measure their JC virus. It's irrelevant. There are about a dozen cases of PML on Ocrevus. Most of those people were on Tysabri or Gilenya before their Ocrevus. And so Ocrevus itself has a very, very rare risk of PML, and I do not measure JC virus levels if I'm going to put someone on Ocrevus. If Ocrevus is the right drug for them, I would not be checking JC virus.
Okay, thank you for that. Next, the person wants to know what your perspective is about switching from a patient from a brand to a generic when the brand is no longer funded.
Yeah, and so this goes back, unfortunately, we've had the opportunity to discuss this already tonight in terms of biosimilars or generics. And so we look at the drug and say, is there a biosimilar or a generic? And you may know that there's a slew of these coming out next year. So we already have options for Copaxone. We have Glatopa and Mylan glatiramer acetate. We have several options already for Tecfidera. My understanding is that there'll be an option for Tysabri next year. There is an option for Gilenya that is going through the courts right now, which probably sooner or later will have the generic Tecfidera. So I think we need to look at these drugs, and for the most part, if you look at these drugs, you look at the manufacturer, you look at the FDA data, how were they compared, how do they work, and for the most part, I think for many people, I'm approving them. If there's a question of someone not being funded and therefore not being able to afford a drug, in general, I'm saying, well, we'll try this, the biosimilar or the generic. Let's try this and monitor you very closely. The only agent that's bothered me a little bit with that is Tecfidera, because there are so many options of the generics. When there's less options, it's easier. You have one or two companies you might be evaluating, but when there's many options, it's a little more difficult to evaluate. But that said, we have quite a few patients on generic Tecfidera for insurance reasons. They elected to choose that instead of switching to another drug like Vumerity. So in general, yes, I'm okaying them. In general, looking carefully at who's the company, what kind of company is it, Are they a good company? And going from there.
So here comes the big problem. And this comes up at a lot of the councils that I'm part of with the health equities and et cetera. For a person that is not on an insurance and is only per se on a government insurance, a generic product might cost them a lot more than a person who has private insurance. Or if they don't have any insurance at all, a generic or a biosimilar could wind up costing them as much as it would have cost them to get the brand. What do you do at that time?
Again, a very individual question and different options that we have in that situation. Option number one sometimes is that a particular drug is not funded. The generic requires a high copay, for example. First option is, so the first option if that happens is to switch to another drug. So going to a different agent. Okay, not always a comfortable thing. Someone has been on a particular drug 5 years, 10 years. Now all of a sudden they have to switch. We know they're doing well on that drug. Actually, what I should say, the first thing is we do is fight. So the first thing is we fight. We fight the insurance company. I can tell you that our fights are not very successful. We have a low win rate. We're dealing with insurance companies and medical directors, and we actually have to speak to a medical director, wasting time, hours. I can tell you sometimes it takes us to speak to them and saying, you know, this person has been on this drug for 10 years and they're stable. It makes no sense to switch. And nothing happens. They just refuse sometimes. So first step is to fight, and often we lose. Second step then is if there's no generic or biosimilar available because it's too expensive, next step is to switch to another agent. And so we have to sit and look and say, is there another agent that is covered? So if this drug was not covered anymore, the copay was not covered, the assistance was not covered, we have to then look into our drugs. Unfortunately, we have a lot of them and a lot of companies, and it's competitive, and say, okay, we know that if we prescribe this drug for you, we're likely to get some patient assistance for you. And that's another option. And then the final option, which is some of you use less these days, but that's research. We may put someone into a trial where they get a research drug. For example, I spoke to you earlier on about our excitement with the BTK drugs. To give you an example of a trial we're doing, it's where you have a BTK drug and the person either gets the BTK drug or they get an active comparator. Then we're not using a trial where they would get a placebo. It would be an active comparator. And that would be something like Aubagio, for example, in a trial. Or a trial might compare it to Avonex, but they're always getting something active. So that would be another way for us to look at this situation.
Okay. So that's why I'm in favor of the drug companies coming out with another drug company coming out with something similar to something that somebody already had out there, because then it opens up the availability for the patients to get, you know, the insurance matters handled through that company directly rather than being turned down altogether. So that is an option. And so when somebody says, oh, there's so many drugs out there that are similar to something else, well, these are the reasons, you know, also that it makes it available for you to be able to get the drug, but sometimes you do have to switch to something else. Okay, so Michael is asking, do you think there is any merit in FMT, which I don't know what that is, since it's directly related to the gut microbiome?
FMT.
That's what he wrote. But maybe you would know what it is.
Okay, look it up, but I don't know. I don't know okay. FMT. Maybe Michael can write back to you and tell you what FMT is.
Exactly. Deborah, in the meantime, Deborah's asking, are there any specific probiotics that have been helpful for MS patients?
Let me just, I'm going to try and type in here while we're speaking. Hold on 1 second. I'm trying to type in FMT here. Just typed in FMT and MS. Okay, I know what he's.
He just wrote it. It's fecal matter transfer.
It's fecal microbiota transplantation.
Right.
It goes back to what I was telling you about earlier about the importance of the microbiome. And what they've done in these kind of studies is they've taken feces and they made feces from a healthy person. This has been done in animals, for example, particularly, but it's been done in some humans too. So they'll take a healthy specimen of feces, make it into a capsule, and they will give a fecal microbiome transplantation. So you're transplanting healthy feces with healthy bacteria into someone's gastrointestinal tract where they have a condition and trying to replace the bacteria with healthy bacteria. So again, this goes to what I said before. I said the microbiome, and looking at the microbiome for the future was something that was very interesting. So yes, fecal microbiome transplantation. Again, experimental right now. But the microbiome, very important area of future research. Many studies going on in the US, Europe, Canada, Australia, many studies going on with the microbiome. This is one of them, of a way to take something from a healthy person's gastrointestinal tract and transplant it to a person that has abnormal bacteria in their gastrointestinal tract. As regards probiotics, there's many different types of probiotics. The one probiotic that I particularly found of interest is called VSL3. VSL number 3, that has been studied specifically in ulcerative colitis, which is another important autoimmune disease that does affect the gastrointestinal tract. There have been small studies of VSL3 in MS. It seemed to be of some benefit, but until we know more about what are the really most important bacteria, giving different probiotics, they all have different bacteria, different amounts of bacteria, different types of bacteria. We're in the infancy of the study of the microbiome, microbiota, fetal microbiome transplant, probiotics, prebiotics. We're in the infancy of studying these items. But I think we'll be talking about them in the next 5 to 10 years. They'll be a major topic for us to talk about.
Great, thank you. All right, next question. Is there patient assistance available for biosimilars and generics?
Yeah, again, it's an individual company. And some of them do have patient assistance is the answer. For example, Sandoz has a biosimilar. I think there is assistance for that. And I think there is some, again, it's an individual thing. They can look at people's insurances. Sometimes they even ask for W-2s. So there's no general answer. There is in some situations assistance.
Great, thank you for that. Next, we have a person asking, in how many years do you think BTK will be available for patients?
Yeah, I'm thinking, so the one BTK drug made by Sanofi was just put on hold. I think it's going to be a short hold because some patients got some liver dysfunction, so they're reevaluating that. I think very soon it's going to go back into the trial, and all it will require is for us to monitor the liver. Many of our MS drugs that we already have affect the liver, so we have to monitor that. We're accustomed to monitoring liver function. But I'm thinking by 2024, our first agent should be in the market. Not before, I doubt that it'll be before 2024.
That's correct. All right, with the NFL biomarker blood test just getting FDA approved, are you using this tool for vital information in your practice?
I'm not using it routinely yet. It's not widely available yet, but it will be, and I think it's going to be a marker. I think it's going to be an important marker, particularly for disease progression. NFL is not specific. That means it's not only something that's seen in MS. You see it in people that have had strokes and other conditions where there's breakdown of nerve cells in their central nervous system. So I think it's going to be a marker. If someone has MS early on, to measure the marker, and if it's high, we would know they have a high disease of activity. And then particularly, I think it's going to be important in monitoring. So I think it's going to be a marker that's great use for monitoring more than diagnosis. It's going to be monitor how someone's doing, an accurate way of monitoring. If the NFL is high, we treat them. 6 months later, we measure the NFL again. It's down. We know we're achieving some benefit. In other words, someone could have an MRI scan, and 6 months later, we see them, and they say they feel great. And we look at their MRI scan, and it looks bad. They've got new lesions. Or the opposite. 6 months later, they come in and they say they feel bad, and their MRI scan looks the same. So MRI scan is a great tool, but it's not always representing the way things are going. And the biomarker, I think the NFL will help us with that. It's going to be an accurate, objective measure. How are you doing? Your NFL went down from 60 to 20. You're doing great. I think that's what it's going to help us with.
Great, thank you. So Kathy asks, is there any advice about travel after Ocrevus? How long should I wait to travel? How long should I wait to fly? Is more specific.
I mean, Ocrevus lowers the B cells, and if you look at people's risk of infection, there are some slight increased risks of infection, Again, I think it depends on the stage. The further you go from the infusion, the B cells will start to recover. The T cells are not affected by Ocrevus. People that get Ocrevus, their T cells are generally normal. The T cells are the first line of fighting against the virus, so they still have T cells. It's not that they're totally unprotected. These are not people that are totally unprotected. They still have T cells. They still have other white blood cells, just the B cells are low. So I would say people have to do travel, take the usual precautions of that we always talk about: masking, hand washing, hygiene, and those kind of precautions, and they are free to travel.
I'll tell you, I'm in the air every week or every other week, and it's unbelievable. It's quite a mix of people that you see out there. So, it's.
But how many are wearing masks? Very few, probably.
Less than half.
Yeah.
Yeah, less than half these days. So, you have to just wonder that, for those that are wearing them, well, they're wearing it as a precaution, whether it be for themselves, maybe possibly being sick and not wanting to transmit, or just staying healthy and not collecting whatever germs are out there.
Yeah,
okay.
Both ways.
All right, next question. So what do we got here? I got a lot of questions. What are your views on the utility of Evusheld? I know you spoke about this before. Has it shown some protection against Omicron subvariants?
Yeah, it's probably got better protection against some of these than some of the early ones. But as I said before, the time that I use it is in the high-risk person. I don't uniformly use it in an MS patient. So in a person with high risk, maybe somebody who's on a drug like Ocrevus and has comorbidities, a person on Ocrevus, an older patient on Ocrevus, a patient on Ocrevus that's got problems, diabetes, high blood pressure, obesity, bladder problems. That kind of person is the person that I would consider Evusheld. I don't uniformly use it in everybody. Just in those kind of people that are the people that are at high risk. By the way, do you know what the average age of an MS patient is in the US? That means almost half the patients are older than that and almost half are younger than that. It's 55. So we're dealing with a population now of MS patients that are aging, and we're dealing with problems now. The population's aging. People are treated much better and so on. So we're dealing with people that have other issues and problems that we have to deal with as well. And so therefore we have older patients. If we're talking about a patient that you referred to earlier, the gentleman of 69, if he has comorbidities like diabetes and hypertension and obesity, in addition to the MS and a progressive MS, that might be the kind of person you would consider Evusheld, as long as they have no cardiac problems.
Okay, thank you for that. Next, we have a person who's asking, sorry about that, I lost my screen for a second. How does one know if a generic biosimilar company is reputable? I saw a news report of a company in India with inadequate oversight in India that was not properly producing the product. So how does that compare with what might be happening here in the United States?
In general, yeah, this is a concern always. It goes back, and this is not just applying now to MS. This goes back for forever, and when generics became available for like anti-seizure medications, and people were getting anti-seizure medications and having seizures. And so what's going on? Well, we realized the pharmacist gave them a generic. What's most disturbing in that regard is pharmacists substituting the generic without telling people. And even patients with MS sometimes that have been on certain drugs, they've told me that they got a generic without even being told. It suddenly was shipped to them. So in general, I like a generic to see where it's manufactured and to see that it's a company. Look it up. Is it a reputable company? For example, Sandoz, as a company that makes some of these biosimilar agents. That's what I would look at. Mylan, that makes a generic GA, glutathione acetate. These are reputable companies that are well known in the generic field or in the biosimilar field or in the field of medicine. I would always look to a reputable company. If I'm going to get a generic, I'd say to the pharmacist, who makes this drug? And if they give some name of some company that's located in the middle of some foreign land, I would probably say no. That's would you have some localized variant that's made by a reputable U.S. company?
Okay, thank you. Next question is, person wants to know if it's beneficial to wear a mask all the time.
I mean, it's controversial. You know, the CDC says one thing one day and then another thing the other day. Joe Biden says the pandemic's over. Didn't he say that the other day? So, you know, I don't know. I mean, we're constantly getting information that people are changing at different times. So I think it's someone's level of comfort. I think that the masks do give us some protection. And if we're in an unknown crowd, if we're in a familiar environment and we know all the people that are there and where they've been, we may not need a mask. But if we're in an environment where we don't know, if you're in an airport where there's hundreds of people, or in a gathering where there's lots of people, is put on a mask. I think there's no harm in putting it on. It does absolutely no harm. It can only help. So when there's doubt, put on a mask.
Okay. All right. Let's go to something totally different. Let's get away from COVID altogether. All right. Is leaky gut curable?
Leaky gut?
Leaky gut.
No, I think it's manageable. I don't know that it's curable. I think it's manageable. So again, this interacts with everything we've spoken about earlier, with the microbiome and the immune system and what someone's having in their diet. And these are all things that we have agents that can manage them, but not, I don't think it's curable. I think it's manageable.
Okay, thank you. All right, next one. Person wants to know what the difference is between rituximab and Ocrevus, and why, if it's the same, why are they using two different names?
No, it's completely different. It's different. It's drugs that work in the same way. So the rituximab is an older drug in this category. These drugs are drugs that reduce the B cells. Remember, the B cells are a type of white blood cell, a type of white blood cell, a type of lymphocyte. They're called B cells. The other type of white blood cell in this category is called T cells. These drugs are anti-B cell drugs. So rituximab is the oldest one. It was shown to be effective against some forms of MS, especially relapsing MS. And it's been used for many other conditions like rheumatoid arthritis and other conditions of that type. Along came Ocrevus, which is a newer drug, and it's more human. Rituximab has got more animal. We spoke earlier, remember, about biologics having biological components, animal components. Well, rituximab has more animal component than ocrelizumab. And a newer drug in that category is ofatumumab, which is Kesimpta. And Kesimpta is 100% humanized. It has all the components are human components. So that's the difference between these drugs, the amount of human versus bacterial component. The more bacterial component it has, the more likely it is your body's going to react to it. So Rituxan is an older drug. The newer drugs, your body's going to form less antibodies to them, so they may be more effective. Rituxan, of course, is old. It's generic already, so it's probably much cheaper. But all of them are working against the B cells.
Okay. Well, thank you for this. We are out of questions. And so I want to thank you again for being here online with us, and we look forward to seeing you again soon.